Следующий докладчик, наш гость из университетской клиники Базеля, Швейцария, доктор Маттиас Грисхабер. Новое в лечении закрытоугольной глаукомы.
Good morning, everyone. It's a great pleasure and honor to be here and to give a talk to you in this session. It's a very memorable and anniversary meeting, and I'm very glad to be here. Today I will talk about angle closure glaucoma, and I will go quickly through the first classification as it's changed in the last years, coming into diagnostic tools we have nowadays, and then talk about differential diagnosis before I conclude with the therapy. So traditional classification has been based on some symptoms and IOP rather than on functional and structural consequences or stages of the disease. We have been distinguishing between acute symptomatic and chronic asymptomatic patients depending on their symptoms and IOP. Also, in the past, we have used the provocative gonioscopy test, which is nowadays obsolete according to the European Glaucoma Society guidelines, as it may be false negative or it may trigger an acute attack despite monitoring. So the current classification is based on the publication of Foster and co-workers, which has been now 10 years ago, and he defined as a primary angle closure suspects as those which had a irregular trabecular contact over 180 degrees or 2 in 4 quadrants, but there are no peripheral anterior synechiae, and IOP is normal, as well as the visual fields and the optic discs. When we have a primary angle closure, a manifest type, then we have, in addition to the previous, we have a, as you see here on the right side, a additional peripheral anterior synechiae, increased IOP, but still a normal visual field and optic disc. And then, of course, definition by glaucoma is if you have glaucomatous damage in the optic nerve head and visual field. So the natural history of primary angle closure, or the cascade, is about 10 to 40% per decade developed from suspect to a manifest angle closure, either having peripheral anterior synechiae or acute or chronic elevated IOP, and within 5 years of those developed 30% glaucomatous optic neuropathy. So the risk factors, I think we're all aware of them, maybe more for the younger ophthalmologists among us. There's a positive history for angle closure, symptoms or family history, usually age over 40. Females are more affected. Hyperopia, however, ametropia does not exclude any angle closure glaucoma. With increasing age, the lens becomes thicker, so cataract is also a risk factor. And epidemiology-wise, Asian race. And there's an interesting studies by Wang and co-workers, which did on 120 subjects each on northern, southern Chinese, Chinese American, and white Americans. And they did like basically everything you can do with the anterior segment OCT, all the parameters measured, the anterior chamber depth, corneal arc depth, anterior chamber width. And they concluded from a multilinear regression analysis that the anterior chamber area and volume was definitely smaller in the Chinese population than in the Caucasians or in the whites. And that was independent of the anterior chamber depth, the width, the area of the iris, and the pupillar diameter. and actual length. So they concluded that the Chinese have, just by anatomy, a more crowded anterior segment than we have. And a further studies was also interesting, that when they measured the thickness of the iris at 750 microns, from light to dark condition was much greater in the Chinese, despite the smaller pupillary diameter. So the Chinese are not happy about that. I think it's not working well here. Coming to the diagnostics, we have some clinical tools. Slit-lamp, our daily work, we have to emphasize and focus on the corneal scleral area, even if a deep essential anterior chamber doesn't exclude any enclosure. So we have to focus on the slit on the right picture. And for any glaucoma suspects, before we define an ocular hypertensive or a normal tension glaucoma, we have to exclude any angle closure. I know it sounds very simple, but as I work in a referral clinic, we often see patients referred with normal tension glaucoma, which have an overlooked angle closure glaucoma. And this is a very old method, but it has been forgotten, I think, of many years. It's the Herick method, where we put the slit at 60 degrees to our view, and we compare the thickness of the cornea to the anterior chamber depth. And the proportion between the cornea thickness and the anterior chamber depth at that point is very crucial. So if it's 1:1 or 1:2, angle closure is unlikely, and it nicely corresponds to the Schaffer grading, as you see here in this table. If the give maybe another mouse, please. If the proportion is 1:4, so there's a potential for angle closure, and the black network is visible. It's not visible. Okay. And if this is now important, if the proportion is below 1:4, there's a high risk of angle closure. And in any case, we have to do a gonioscopy. So what we look for in gonioscopy, we have to recognize angle landmarks, we have to consider the level of iris insertion, the shape of the contour, estimated width of the angle approach, and the degree of trabecular pigmentation. And the great advantage of gonioscopy is that we can distinguish between irretrabecular contact or apposition from permanent adhesions, such as the PAS, with indentation. So by indentation, we try to open the angle width, and if it's not possible, we have synechia, as shown on your right side. And if it's open, it's only contact. So we can distinguish between primary angle closure suspects from manifest angle closure. A further interesting sign is to detect plateau iris if you have the double hum sign, which I'll show you later. In our institution, we have ultrasound biomicroscopy with a 50 and 80 megahertz. You can use either a funnel or a single-use cover, the water bath. And the great advantage of UBM is there's cross-sectional imaging. We can detect different mechanisms. However, the disadvantage are the costs, and there's no indentation to distinguish between suspects and manifest angle closure. Anterior segment is imaging, such as OCT, is very widely used. The big advantage compared to UBM, there's no contact, there's easy handling. Basically, a photographer can do that. High resolution, and it's very rapid. However, the great disadvantage is that we cannot see structures behind the iris, as you see in the next slide here. So, on your right picture down, is OCT, you don't know what's behind the iris, if the lens is thick, if there's a tumor, and this can be better seen with UBM. So personally, I prefer to do a UBM than anterior segment OCT. Okay, now the joke is now already. So as you see here, there's a very narrow slit, and you might think it could be also an angle closure glaucoma. And if you do a UBM, as I just showed before now, there's a large cyst just closing up the angle at that position. So UBM is my preferred method in addition to gonioscopy. Coming now to the differential diagnosis, we can distinguish between primary angle and secondary angle. Pupillary block is the most common one. I go through quickly as I emphasize later these different types. Plateau iris, where we have a deep anterior chamber, a flat curvature of the iris, then lens-induced mechanism in the elderly patient, and the most threatening one is the aqueous misdirection, or also called malignant glaucoma. Secondary causes are divided by an pulling or a pushing mechanism, either through a contracture of a membrane and adhesion, such as neovascular glaucoma, uveitis, eye syndrome, or a pushing mechanism in the intumescent lens, uveal edema, tumors, ciliary body cysts, etc. So in the primary types of angle closure, pupillary block is still the most common one. It is typically seen those which have a flat anterior chamber and is a forward bowing of the iris. And on UBM, we see a very deep posterior chamber in this type. Those without the pupillary block can be a crowding of the iris, as seen on your left side, plateau iris, or lens-induced. And plateau iris is basically like an anomaly of the ciliary body, which is anterior-rotated, and there's a short anterior-positioned iris basis, which leads to a crowded angle. We can distinguish between a configuration, which is a functional type of plateau iris. As seen here is a flat iris curvature with a deep anterior chamber centrally. And the syndrome is then when it still stays a closed angle after a patent iridotomy. Difficult to see, but diagnostic useful is the double hump sign. There's a peripheral hump which refers to the anterior rotation of the ciliary body, then a space in between, and then the central hump close to the pupil, which refracts the anterior surface of the lens. Plateau iris is very common, I think much more common than you think. There are different studies demonstrating that in people which had an angle closure and a patent iridotomy, 50% of them had a plateau iris. This is shown in the European population, in the American population, and also in the Asian population. And in a study, epidemiological study, the prevalence of plateau iris was about 10% in southern China. So it's quite common. And this is important for the therapy. The last type of the angle closures are the lens-induced ones. They typically have a shallow central anterior chamber depth. And importantly, again, after iridotomy, it's still very shallow. And as you've seen here on the UBM on your right bottom, there's a very thick lens, and the lens is out of proportion to the anterior chamber depth. So this needs cataract surgery. Of course, there's always mixed mechanism. You can have partially lens-induced, partially pupillary block, partially plateau iris, which makes the definition a bit more difficult, but the treatment, as I'll show you later, is still straightforward. So, therapy, we just have to avoid any blockage of that angle and an acute attack. And as we all know, iridotomy is the first therapy we can do. Give first spersocarpine to bring the pupil down. And the idea of the iridotomy is to equalize the posterior and anterior pressure. As shown in this slide here. But we still have to keep in mind that about 1/3 of patients which have a primary angle closure and increased IOP, the disease still progresses. Even the iridotomy was successful. So we still have to monitor them for many years. Plateau iris, as told you before, usually the angle is still very narrow or even closed after iridotomy. We can either do an iridoplasty. The idea is to shrink the peripheral iris and to open, as shown on these bottom slides, and to open the angle. However, and that's why I say in the mixed mechanism, this is not very helpful. Maybe the iris is a bit shrink, but still due to the thick lens, the angle is still closed. So a lot of patients, they still need cataract surgery. Just go for time reasons. So take-home messages, mechanism of angle closures are manifold. Pupillary block is still the most common one, but plateau iris is more common than we think. So we have to look for plateau iris. Multiple mechanisms may occur concurrently. It's important to do the correct diagnosis. The reference exam is still gonioscopy, with the great advantage to distinguish between suspects and manifest angle closure by indentation, but it's only half of the truth regarding the mechanism. OCT is a very rapid and useful screening method, with the disadvantage of not looking to the structures behind the iris. So the best tool is UBM. It is an objective quantitative imaging device which displays deeper structures, and we should do in any therapy refractory cases a UBM, especially those which are unilateral, asymmetric, or we have a funny iris contour. Treatment immediately, of course, in any acute angle closure attacks. Time is vision. Laser iridotomy is the first choice. It is useful for all, but not sufficient in all. So either we can do iridoplasty, or what we do actually more common than iridoplasty is go straight to cataract surgery. I thank you for attention.